finally we are here, and sorry for the delay, but I'm so glad that everybody's here. I think just, reviewing the rare and challenging breast cancer is so important because it may be only a small percentage of breast cancer, but once you miss it, it could actually be a detrimental for your, patients and then their family's life. So we are a little bit short on time, so each speaker will have about 25 minutes of talk, and I will have a very short introduction. And after that, all of the speakers speak. We'll have a question session, and you can also post your questions on the San Antonio the website, and then we'll be able to maybe answer them later as well. So the first speaker, no introduction is needed, Dr. Georgie Hayes Philo. He's been the pioneer of all of these the rare breast cancer pathology. He's defining a new rare subtype of breast cancer. He's currently chief of experimental pathology service at Memorial Sloan Kettering Cancer Center. So, Doctor, please.
Thank you so much. Thank you. Can you hear me? Okay, good. So first of all, it's an immense pleasure to be here with you today and to have a chance of participating in this most exciting session about one of my favorite topics, challenging subtypes of breast cancer. Today, I've been asked to talk about the pathologic subtypes, so I'll not be talking about the clinical subtypes such as inflammatory breast cancer and other clinical subtypes. And things are falling on me here. The stage is coming apart. Anyhow. Yeah, I start with a bang. Anyhow. So these are my conflicts of interest. And in the next 25 minutes, what I'd like to do is to recap with you what histologic special types of breast cancer happen to be. It's a conspiracy against me, anyhow. Then, after discussing with you what they are, I'm going to focus first on the most frequent form of histologic special type, the invasive lobular carcinomas, that were mentioned quite extensively in the tumor board session that happened at 1 p.m. today, and then go on to discuss with you the rare histologic types. And I'll divide them into the ER positives and the triple negative subtypes, with an emphasis on metaplastic carcinomas and low-grade forms of triple negative disease. So it's a lot to cover. So histologic special types of breast cancer, for those of you who are not pathology aficionados, constitute histologic entities that we pathologists can recognize when we look down the microscope. And there are over 20 of those recognized in the latest WHO classification. These tumors are defined on the basis of their histology. And I have to say something that may come as shocking for many of you. When we pathologists render a diagnosis of an invasive ductal carcinoma, we have to render it after we have ruled out all of the other special histologic types. A diagnosis of the garden variety of breast cancer is a diagnosis of exclusion. What's interesting is that not only have we now recognized that these histologic entities do exist, but they have important clinical implications. And several retrospective studies have now illustrated the fact that some of these histologic special types have a much better outcome than ductal carcinomas, even when adjusted for the intrinsic subtypes, like in this study here from the Milan group, where they adjusted for luminal A and luminal B, and tubular and cribriform had a much better outcome than ductal carcinomas. What I would like to discuss with you in this talk is not about the clinical implications. This will be discussed in the subsequent talks. Here, what I'd like to discuss with you is whether, at the molecular level, these histologic special types of breast cancer would be more homogeneous than what we see with the invasive ductal carcinomas, and whether they would have distinct biology through the presence of pathognomonic or disease-defining genetic alterations, and whether their drivers would differ from the drivers of the garden variety of breast cancer. And of course, if I'm giving this talk here today, it's because all the answers to these questions are all yes, yeah? But anyhow. So starting with invasive lobular carcinoma, as I mentioned, it's the most frequent histologic special type of breast cancer. It was described in 1941 at Memorial Sloan Kettering, as a matter of fact, by Foote and Stewart. The term lobular carcinoma does not have any histogenetic implications. It does not mean that the cancers came from the breast lobules. Actually, the term lobular carcinoma refers to a constellation of histologic features that we pathologists came to understand over the decades. These tumors are characterized by this population of monomorphic cells that display a remarkable discohesiveness and infiltrate the breast stroma as single cells or single cell files. And often when they invade the adjacent normal breast structures, they invade it in this targetoid pattern, encasing the original normal structures. The nuclei are usually round to ovoid and sometimes ellipsoid, and these cells not uncommonly have intracytoplasmic lumina, like these two here. The nuclear grade of lobular carcinomas in the classic variant is usually grade 1 or 2 in over 85% of cases. But this is the classic variant of invasive lobular carcinoma. There are many histologic variants of lobular carcinoma, including the alveolar, where the cells show that dyscohesiveness but grow in the form of bunches of grapes. There's the trabecular, the solid variant, where sometimes it's even hard for us pathologists to differentiate between the lobular or lymphoid neoplasm. There's the histiocytoid variant, where the neoplastic cells look like foamy macrophages, and there's a signet ring variant that is composed of these isolated cells with these intracytoplasmic vacuoles and that resemble a signet ring. Two variants are of clinical import: the mixed variant with lobular and ductal components, and of course the pleomorphic variant. That bears all the features of the classic variant, but the one fundamental distinction: their nuclei are bigger, more atypical, more pleomorphic, reflective, of course, of their genetic instability. From a perspective of biomarkers, if you think about the classic lobular carcinoma, invasive lobular carcinoma, these tumors are ER positive, PR positive, HER2 negative in greater than 90% of cases. From a PAM50 perspective, the vast majority of these tumors are luminal A, with some being luminal B. And of course, there are some that are classified as normal breast-like, and this is expected given the infiltrating pattern and encasing the adjacent normal breast structures. From the perspective of the genetics, lobular carcinomas are very homogeneous, the classic variant. They have diploid or near diploid genomes with gains of chromosome 1q, gains of chromosome 16p, and deletions of chromosome 16q. And the target gene of the 16q deletions has been identified now for many decades. It is the CDH1 gene that encodes for icadirin, and loss of icadirin is found in over 90% of invasive lobular carcinomas. As a matter of fact, in the context of breast neoplasms, biallelic inactivation of icadirin, the CDH1 gene, is pathognomonic for lobular carcinomas. The biallelic inactivation cannot be a single allele. So the CDH1 gene encodes for icadirin, as I mentioned, and icadirin is an adhesion molecule that mediates homophilic and homotypic adhesions. In plain English, for two epithelial cells to stick together, they require normal levels of icadirin or an intact icadirin pathway. Icadirin is inactivated in lobular carcinomas throughout the spectrum of lesions, from atypical lobular hyperplasia, lobular carcinoma in situ, and invasive lobular carcinoma. And the mechanisms of icadirin inactivation include mutations, deletions, homozygous deletions, more recent rearrangements. There's an unpublished study by Dr. Freja Pareja, and a gene promoter methylation as well. From a genomic perspective, in the last 10 years, we got to understand a lot about lobular carcinoma genomics. And these two studies, one by Giovanni Ciriello and Terry King, in a landmark study from the TCJ group, and also a beautiful study by Christine Desmet, we got to understand what are the genes recurrently mutated in these tumors. And here are classical oncoprints, where each column is, this one here, each column is a tumor, each row is a gene. The ticks here are mutations, color-coded according to the legend. So as you can see, icadirin is mutated here in over 65% of cases, but if one uses more sensitive methods or the samples are more enriched for cancer cells, then this percentage goes up to over 80%. We see several of the usual suspects in terms of genes mutated in luminal tumors, such as PIK3CA, RUNX1, MAP3K1, GATA3. But we see an interesting high prevalence of TBX3 and FOXA1 mutations. And in the study by Christine Desmet, we've seen a high prevalence of mutations affecting HER2 and HER3, which are targetable and very interesting. In a very detailed and elegant comparison that Giovanni Ciriello did in their study, they compared luminal A ductal carcinomas versus luminal A lobular carcinomas in terms of the genes recurrently altered, mutated, or deleted, or amplified. And they demonstrated here that the outlier is CDH1 that is only present in the lobulars, but they could find an enrichment for P10, for TBX3, and FOXA1. Another analysis that is really intriguing is that when lobular carcinomas then are broken into the different variants, there are some subtleties in terms of the genetic alterations. For instance, the alveolar variant here has some additional genetic alterations, but the ones that become really interesting are the mixed here, where you have an enrichment for p53 and HER2 alterations, and of course the pleomorphic lobular variants that in the solid variants that are enriched for higher levels of genetic instability, greater degrees of genomic complexity with a multitude of copy number gains and losses, illustrating that these variants, the solid and the pleomorphic, have a greater deal of genetic lesions. In a comparison of metastatic with primary lobular carcinomas, our team recently demonstrated that, of course, we expect to find the same drivers that we find in primary lobular carcinomas in the metastatic, but there was some interesting enrichment here, as expected for ESR1 mutations in metastatic lobular carcinomas, as well as an enrichment for p53 mutations, probably an enrichment for the pleomorphic variant in the metastatic setting, and NF1 mutations as well. The other observation that we made that I would like to share with you is that in lobular carcinomas that are metastatic, we saw a disproportionate enrichment for apoBAC mutagenesis. Here, in these three concentric circles, we have here on the outer ring the metastatic lobular, in the middle ring the metastatic ductal, in the inner pie here the primary lobulars. And if you look at the green here, that's apoBAC mutagenesis, there's a substantial enrichment for apoBAC mutagenesis in the context of metastatic but not primary lobular carcinomas. And these initial preliminary observations were confirmed in a recent presentation that Dr. Antonio Mara gave at ESMO this past year. Now, moving on to the rare histologic types of breast cancer. And here, the question that I mentioned before, whether they would be more homogeneous than ductal carcinomas, actually the answer is yes. There are some histologic special types of breast cancer that are almost invariably ER positive, HER2 negative, using, of course, the HER2 old definition of HER2 positive versus negative, yeah? And these include mucinous, neuroendocrine, micropapillary, and papillary. There are some that are preferentially of triple negative phenotype, like the metaplastic, secretory, adenoid cystic, and acinic. Interestingly enough, if one does a molecular classification of these subtypes, they very often come back as basal-liked. And there's another subset of special types that are of triple negative subtype, but they consistently express AR. And they are more similar to luminal androgen receptor types of triple negative disease. And this includes the carcinomas with apocrine features and the pleomorphic lobular carcinomas when they are ER negative. So looking at the genomics of rare types that are preferentially ER positive, HER2 negative. And here, for instance, we have tubular carcinomas. Our group and others investigated them, and actually we did not find much. We found that these tumors, like low-grade ER-positive ductal carcinomas, harbor deletions of 16q and gains of 1q. We could not find any pathognomonic mutation, but we found that they very frequently have those mutations that are found at the very low end of the spectrum of luminal way ductal carcinomas. Interestingly enough, when we looked at mucinous and neuroendocrine tumors that are almost invariably ER-positive, HER2 negative, here we found something very different. These tumors, unlike the common forms of ER-positive, HER2-negative disease, they don't have deletions of 16q and gains of 1q. We could not find any pathognomonic mutation, but we observed that PIK3CA and AKT1 mutations are almost never found in these tumors, despite the fact that they are ER-positive. They harbor mutations in GATA3, the mucinous, and the neuroendocrine have mutations in chromatin remodeling genes, in a way akin to neuroendocrine tumors of other anatomical sites. one aspect that was really striking for me is that when you look at the profiles of mucinous and neuroendocrine, they're much more similar to male breast cancers than to the conventional ER-positive, HER2-negative ductal carcinomas in women, perhaps indicating a different progression pathway. Much more studies are needed now, I'm afraid to say. Now, moving on to the special types of triple-negative disease. And here we have two groups. One group characterized by high-grade, high genomic complexity, that include metaplastic carcinomas, carcinomas with medullary features, and carcinoma with apocrine features. And we have a second group here that's really fascinating, where tumors are of triple-negative phenotype, but they are of low grade, have low genomic complexity, and go by really esoteric names. And we'll talk about them in a second. But for now, what I'd like to do is to focus on metaplastic carcinomas, and we'll have an in-depth discussion about these tumors in a separate talk. So metaplastic carcinomas are tumors that have fascinated pathologists for many, many decades. They are characterized by a complex admixture of neoplastic cells that differentiate towards elements that are not usually found in the normal breast, including spindle differentiation, squamous differentiation, sometimes with multiple types of sarcomatoid differentiation, such as chondroid in the form of chondroid areas or bizarre giant cells. Some of them even resemble fibromatosis lesions with low-grade spindle cells in a fibromyxoid stroma. These tumors are rather rare, accounting for 0.2 to 1% of all invasive breast cancers, depending on the definition of metaplastic carcinomas used. And from a genetic standpoint, they're really intriguing. We carried out an analysis of 35 of those using whole exome sequencing, published a few years ago. Here's in this oncoprint, we have in each column a tumor, each row is a gene, each square here is a mutation, coded according to the legend here. And disappointingly, when we looked at the metaplastic carcinomas, we did not find anything new in terms of a new gene-altered pathognomonic alteration. We found that they have 53 mutations, and that actually, when compared head-to-head to high-grade invasive ductal carcinomas of triple-negative phenotype, they have an enrichment for mutations affecting PI3K pathway-related genes or Wnt pathway-related genes. And when they harbor these mutations, they do display at the mRNA level an activation of the respective pathway. These tumors, despite the high grade and complexity, phenotypic and genomic complexity, they're usually of low or intermediate tumor mutation burden. And in terms of the signatures, and here's an area of great confusion. The majority of them display an aging mutational signature, just cell divisions. And there's a subset that displays some of the features of HRD. If you do a whole exome and look at mutational signatures 3 and 8, they seem to be enriched for those. But we recently did the Pepsi challenge and whole genome sequencing of some of these lesions, and actually most of them, it's just a partial HRD. They are not true HRD cancers, unless they harbor a BRCA2 or a BRCA1 biallelic alteration. We have examples of those as well. Another important observation about metaplastic carcinomas is that most likely we are dealing with a really heterogeneous spectrum of lesions. And this comes from Britta Weigel's study, where her group profiled the independent components of metaplastic carcinomas using transcriptomes and used also the whole exome data. And for instance here, each column here is a component of a metaplastic carcinoma, and then the intrinsic subtypes, the triple-negative subtypes, BRCA-NES, and the integrative clusters. And suffice it is to say that we observe that the classification, for instance, with the intrinsic subtype, varies according to the differentiation. The spindle cell carcinomas are almost invariably of Claudin-Low subtype. With squamous can be Claudin-Low or basal-like, whereas the chondroids seem to be enriched for the basal-like subtype, with some here being classified as normal breast-like. From a genomic perspective, then when we looked at the different components, and this based on small numbers, and it's a very busy figure, I just want to give you the highlights, is that when we look at the different metaplastic carcinomas according to the lineage of differentiation, there are differences. For instance, the spindle cell carcinomas less frequently harbor p53 mutations, whereas the chondroids harbor less PIK3CA mutations and less H3 gene promoter mutations, suggesting that there is a transcriptomic, and a genomic diversity within metaplastic carcinomas. So whether it's correct for us to lump all of them together or not is a different proposition. And the final point about metaplastic carcinomas is the fact that these tumors, in a few studies now, including studies that were carried out at Memorial Sloan Kettering, have revealed that these tumors very frequently express PD-L1 at clinically meaningful levels, using the cutoffs that have been used as indications for immunotherapy. Again, whether this is an effective treatment for metaplastic carcinomas will be discussed later. Now, to finalize this talk, my favorite topic of all, the low-grade forms of triple-negative breast cancer. And as I mentioned, they go by really esoteric names like secretory carcinoma, adenoid cystic carcinoma, mucoepidermoid carcinoma, polymorphous adenocarcinoma. These tumors have several characteristics in common. They are almost invariably of triple-negative phenotype. And when profiled with gene expression profiling methods, they very often come back as basal-like, and we did do the Pepsi challenge. Despite the fact that they're of triple-negative phenotype, they have an indolent clinical behavior, and retrospective studies suggest that the benefit of chemotherapy for those patients is rather modest, very different from the garden variety of triple-negative disease. They're really rare in the breast, but they can be present in the lungs, and they are not uncommon in the salivary glands, hence the name of the group, salivary gland-like tumors of the breast. They have another characteristic in common. Each one of them is driven by a highly recurrent, if not pathognomonic, genetic alteration. Secretory carcinomas, as Paul Sorensen's group demonstrated, they are driven by the ETV6 and TRAC3 fusion gene in over 95% of cases. Adenoid cystic carcinomas are driven by the MIB and FIB fusion gene in over 70% of the cases. And when this fusion gene is not present, what has been found by Britta Weigel's group is that they have MIB-L1 rearrangements, and if not that, MIB gene amplification. Mucoepidermoid carcinomas, as Freja Pareja and our team shown, that they are driven by MEML2 fusion genes, and polymorphous adenocarcinomas are driven by the PRKD1 hotspot mutation, 73% of cases, and when it's not present, it's by PRKD1, 2 or 3 rearrangements. And importantly, these tumors do not have p53 mutations, have very simple genomes, and are driven by these specific alterations. And for those, and you may have heard this before, there are no genotypic-phenotypic correlations in breast cancer. I think I've just given you quite a few today. And the second point is that there is evidence of convergent phenotypes in breast cancer. For instance, adenoid cystic carcinomas are a disease of MIB pathway activation, regardless of the genetic alteration. And polymorphous adenocarcinomas are driven by activation of the PRKD family of genes. And I would contend that these observations made the histologic subtyping of triple-negative breast cancers absolutely essential in the clinic. Because, okay, the majority of them are high-grade tumors that are chemosensitive, they have an aggressive clinical behavior, and so on and so forth. Most of them are invasive ductal carcinomas of no special type. And as I mentioned, some special types almost invariably display triple-negative phenotype, like medullary, metaplastic, and apocrine. These tumors have complex genomes with p53 mutations, the whole story that we discussed. But now we understand that this is not the whole story of when we say a triple-negative lesion. We have this subset of low-grade forms of triple-negative breast cancer that have fundamentally different biological features, natural history, response to treatment, and the fact that we are lumping all of them together makes absolutely no sense. And I would contend that understanding the biology of these ones, based on the presence of these specific alterations, makes it even more important, because one of them, secretory carcinomas, thanks to the work of beautiful work of our colleague Alex Drillan and many others, secretory carcinomas now constitute, when they are relapsed or locally recurrent, they constitute an indication for the use of TRK inhibitors. So histotyping triple negative disease, it's essential. And if your pathologist is not doing it, you have to tell him or her to try again. And that would be my recommendation. With that, I'd like to conclude, and I hope that I have persuaded you, that special histologic types of breast cancer have not only distinct histological appearances, but also different genomic features and biological characteristics. I hope I had demonstrated to you that there are some specific genotypic, phenotypic correlations that do exist in breast cancer. And I mentioned CDH1 in lobulars and all of those alterations in the low-grade forms of triple negative disease. And I really hope that I've shown you that studying these rare forms is much more than tumor philately. I'm not only doing stem collection. Actually, understanding these tumors and subtyping them will be challenging. And I'm not going to say that it's easy. There's a great deal of inter-observer variability that we still have to improve on. But their subtyping does indicate different biology and likely going forward, different therapeutic approaches. With that, I'd like to thank you for your attention. I have to thank many people in my team, in particular Freja and Britta, our collaborators, and of course BCRF. BCRF has been an incredible supporter of our study of rare tumor types for the last 10 years. And I'd happily take any questions you might have at the end of this session. Thank you.
Thank you very much for the wonderful overview. So now we're going to have a nice transition to the clinical aspect. So we're going to expand what we learned from the pathology and how we can acknowledge and expand those knowledge into the clinic. So the next wonderful speaker is Dr. Alexandra Thomas, who is the professor in the Wake Forest University and then leader of the breast cancer disease-oriented team and a co-leader of the Breast Cancer Center of Excellence. And she's going to give us the overview and how we might actually change the practice after you go back home today. So, Dr. Thomas.
Thank you so much, Dr. Lim. It's a pleasure to be here. Good afternoon, everyone. I'd really like to thank the organizers for the opportunity to speak on this important topic at this important session. Yes. We're just going to, there are my slides, just perfect, and I cleaned up here, so we're ready to go. Next slide, please. Oh, I got to do it. Thank you. These are my disclosures. So I've outlined our discussion today on metaplastic breast cancer, the road forward, to include first a review of the epidemiology and clinical features of metaplastic breast cancer. Then we'll look at the molecular and pathologic features with a focus on how these might suggest therapeutic vulnerabilities, and Dr. Reisvilho has just given a fantastic lead-in. Next, we'll look at current and emerging treatment options in this space. And finally, we'll look at contemporary tools and how with these, and perhaps a little bit of creativity, we might be able to further our understanding in this space. To provide a framework for where we're headed, let's talk first about the take-home messages of this afternoon's discussion. First, metaplastic breast cancer is seen with some frequency in clinical practice. Second, prognosis for metaplastic breast cancer is generally worse than for other breast cancers, though there are some notable exceptions. Enhanced molecular understanding of metaplastic breast cancer and newer therapeutic options provide reason for optimism. Finally, newer research tools, which often harness technology, offer the promise of further disease-specific understanding. Metaplastic breast cancers are unified in their ability to differentiate into squamous or mesenchymal elements. But beyond this, they are highly heterogeneous. So I will discuss them as one group. The phenotype and clinical behavior of individual metaplastic tumors can vary widely. Discerning the incidence of metaplastic breast cancer is complex due to multiple overlapping possible diagnosis codes. One recent SEER review used a single diagnosis code and found that metaplastic breast cancer represents approximately 1 in 200 cases of breast cancer. Using a broader definition, this proportion increases. A reasonable conservative estimate is that approximately 1,000 to 2,000 new cases of metaplastic breast cancer are diagnosed in the United States each year. Variability in making the diagnosis, in addition to overlapping diagnosis codes, likely contributes to our incomplete understanding of the incidence of metaplastic breast cancer. So how rare is metaplastic breast cancer? One way to think of this is in the context of other less common solid tumors, shown here esophageal and anal cancer. To start with, we have an apples-to-apples comparison of incidence for 100,000 persons in the US, with the reported incidence of metaplastic breast cancer shown in solid pink. Though for these tumors, this is likely an underestimate, as these tumors can be registered into a variety of categories. For example, diagnoses which would not have been included with the classic metaplastic breast cancer include spindle cell carcinoma, carcinosarcoma, and others. Other series estimate that metaplastic breast cancer can range from 0.2 to 1% of all breast cancers, again, depending upon the definition. Shown in the light pink bar on top of classic metaplastic breast cancer is the possible extent of this tumor type. Metaplastic breast cancer approaches the prevalence of less common but well-studied solid tumors. Shown here are several reports which discuss the incidence of metaplastic breast cancer globally, acknowledging all the imperfections of cross-study comparisons, especially in the registration of uncommon tumors. This allows us to start thinking about the burden of this disease globally. The definitions of breast cancer varied, but generally cited using ICD-0, 3rd edition, or searching by terms such as osseous or squamous. Across the globe, the incidence varied from 0.5 to 1.9% of breast cancers, and incidence of advanced disease at presentation was higher in developing countries. Turning now to the clinical features of metaplastic breast cancer. Median age is slightly older than that seen with invasive ductal carcinoma and NOS. The incidence appears to be slightly higher in Black patients than in patients from other racial groups. Metaplastic breast cancer, as Dr. Rice-Fieldhope pointed out, is most commonly triple negative, but not always. Lens lymph node involvement is seen due to more frequent hematogenous rather than lymphatic spread. These tumors present frequently with stage 2 to 4 disease on the basis of large tumor size or de novo metastatic disease, and they frequently have aggressive imaging features on MRI. Multiple studies have demonstrated inferior clinical outcomes for patients with metastatic disease relative to patients with triple-negative breast cancer broadly. A recent review of the National Cancer Database looking at over 65,000 patients with stage 1 to 3 triple-negative breast cancer demonstrated inferior survival for those with metaplastic breast cancer shown on the left. Another NCDB-based study reported the striking 90-day mortality of 2.3% with metaplastic breast cancer, not something we see often in our space. This study also showed a 5-year mortality much higher than what we're used to seeing across breast oncology broadly. Further evidence that these tumors frequently have aggressive biology comes from a recent series which looked at oncotype scores in 26 metaplastic breast tumors and found that 69% of these had scores higher than 25, relative to 16% of those with invasive ductal carcinoma, NOS. Our recent study compared outcomes by receptor-based subtypes for metaplastic breast cancer with invasive ductal carcinoma not otherwise specified. Outcomes for triple-negative and HER2-negative, hormone receptor-positive metaplastic breast cancer were inferior relative to triple-negative carcinoma, with differences becoming more pronounced by stage. Though in a bright spot, the small number of patients with HER2-positive metaplastic breast cancer had outcomes which paralleled those with HER2-positive invasive ductal carcinoma. While most metaplastic breast cancers are aggressive and high-grade, low-risk histologies do exist and are important to identify. These include low-grade adenosquamous and fibromatosis like metaplastic carcinoma. The World Health Organization has 4 classes of aggressive histologies listed here. Outcomes vary somewhat by histology, as shown in this recent series of 132 cases seen at Memorial Sloan Kettering. This work found that survival outcomes are inferior with squamous cell and best with mesenchymal histologies. For mixed metaplastic carcinoma, survival decreases with increasing number of metaplastic histologies. Let's turn now to look at molecular features with an eye towards if this provides clues or a roadmap for more effective therapeutic options. I love pathology, just like Dr. Rice-Fieldhope, even though I'm a breast oncologist. And so this is just a reminder of the metaplastic histology we're discussing. This is a mixed histology metaplastic carcinoma that features a spindle cell component with a bluish stroma shown on the upper left. The image on the right is an enlargement of the same tumor, demonstrating in high power the keratin pearls seen on the right portion of the lower power slide. Where do metaplastic breast carcinomas fall with regard to intrinsic subtype and triple negative subtype? Shown here is this elegant work completed by Dr. Rice-Fielho's lab. Most metaplastic breast carcinomas fall into the Claudin low or basal-like intrinsic subtype. In this work, the tumors with this predominant spindle cell component were uniformly Claudin low. The triple negative breast cancers most commonly identified in metaplastic carcinoma were mesenchymal and basal-like. The Peru lab recently looked at this with intriguing findings in the TCGA dataset. In the context of the TCGA pan-cancer atlas samples, they analyzed the distribution of breast cancers with special histologies, including 14 metaplastic breast tumors according to the clustering of cluster assignments pan-cancer grouping, which has 24 major molecular subtypes. Most breast tumors fell into groups 20 or 23, which correlate broadly with luminal and basal-like breast cancer. However, 7 of the metaplastic breast cancers, the other 7, had non-breast predominant signatures and fell into groups 4, 7, and 8. 4 of these, which were Claudin low, fell into groups 4 and 8, which were predominated by sarcomas and melanomas. All 4 of these metaplastic tumors had mesenchymal components. 3 metaplastic tumors were predominant squamous and clustered into the other group, which is typically associated with head and neck, cervical, lung, esophageal squamous cell carcinomas. This work also found that metaplastic tumors, in particular those of the Claudin low subtype, are among the least differentiated breast tumors. Metaplastic breast cancers have an overrepresentation of potential targets, including DNA repair, PIK3, MEK, and Wnt pathways. Shown here are possible targets which vary by predominant histologic component of the tumor. What is the rate of PD-L1 positivity? Are there any suggestions that these tumors might be more vulnerable to immune therapy? Shown here are the findings of the Memorial Group, which were touched upon also by Dr. Rice-Fielho, which examined PD-L1 status in 42 treatment-naive metaplastic cancers across a variety of PD-L1 platforms and cutoff criteria. Consistent with the work of others, this shows that PD-L1 positivity relative to what we typically see in invasive ductal carcinoma is higher with metaplastic breast cancer. Another study recently reported PD-L1 positivity using a single cutoff point in metaplastic breast cancer relative to other breast cancer subtypes and demonstrated markedly higher PD-L1 positivity with metaplastic breast cancer. Other features which are overrepresented in metaplastic breast cancers and which might suggest susceptibility to checkpoint blockade or immune-based approaches are stem-like features, variable T-cell infiltrates, and their occasional high tumor mutational burdens. Whether these clues will predict for consistent responsiveness to checkpoint blockade in metaplastic breast cancer remains unclear. With regard to potential targets in metaplastic breast cancer, what do we know about HER2 low? At present, we know very little, but I hope that we'll know more soon, hopefully at meetings like this. One recent study reported a HER2 low rate of at least 8%. Can we extrapolate from the HER2 positive story that these tumors will be vulnerable to HER2 low antibody-directed therapy? While perhaps incremental, given the high-risk nature of metaplastic breast cancer, disease vulnerability here could be meaningful. With this backdrop of potential molecular targets, let's turn now to look at a practical level at which therapies are working and which we might want to study further. What about chemotherapy? In the short, chemotherapy can work with metaplastic breast cancer, though at rates that much lower than what we typically see with breast cancer broadly. On the left are pathologic complete response rates observed in recent series of patients who received neoadjuvant therapy. On the right are response rates by agent class for metaplastic tumors in the early and late line settings. Again, these are lower than what we typically see for breast cancer broadly. Still, multiple large registry series suggest benefit to chemotherapy relative to no chemotherapy and benefit to radiation therapy relative to no radiation therapy. What do we know about the role of anti-estrogen therapy and HER2-directed therapies in metaplastic breast cancer? While direct data are quite limited, we can extrapolate some information from prognostic results. Indeed, disease hormone receptor status is not prognostic in most metaplastic breast cancer series. In contrast, HER2-positive status has been associated with improved survival, likely on the basis of receipt of HER2-directed therapy. This is shown in the survival curves on the right, which looked at survival by tumor receptor status by stage for metaplastic breast cancer on the left and invasive ductal carcinoma on the right. For metaplastic breast cancer, patients with HER2-positive tumors, shown in blue, do better, with this effect being more pronounced with increasing stage, while patients with hormone receptor-positive tumors, shown in red, track with triple-negative metaplastic breast cancer. In invasive ductal carcinoma on the right, outcomes for HER2-positive tumors track consistently with those of hormone receptor-positive tumors and are superior to triple-negative breast cancer. This table summarizes what we know about responses to established therapies in metaplastic breast cancer. These therapies work, but they just often don't work as well as they do in breast cancer NOS. Multiple caveats must be noted. These data are largely retrospective with limited, if any, prospective predictive information. Many series are small and extend to earlier eras. The impact of therapy on the mammary component of mixed metaplastic breast cancers is less clear. And finally, metaplastic breast cancer is highly heterogeneous, and the impact of therapy on individual tumors can vary greatly. What can we learn from the few clinical trials that have been conducted in metaplastic breast cancer? This phase 1 study looked if combined mTOR inhibition and liposomal doxorubicin with bevacizumab could have activity in mesenchymal metaplastic breast cancer. The premise was that targeting the PI3K and related pathways could enhance response to chemotherapy. The investigators should be congratulated on accruing 52 patients at a single center over 5.5 years, a time period long enough that the mTOR inhibitor was changed from temsirolimus to everolimus. Some patients had remarkable responses, as demonstrated in the waterfall plot on the right. Overall, the objective response rate was 21%, with responses more likely to occur in these patients with tumors with pathway aberrations. Another clinical trial success in this rare disease, although I'm trying very hard not to say rare and say uncommon more often, is this work from cohort 36 of the DART study, which was led by Sylvia Adams. The DART trial offered combination nivolumab and ipilimumab to patients across a range of baskets of uncommon tumors. Cohort 36 studied patients with metaplastic breast cancer and quickly completed accrual. Shown here are the swimmer's plots of responses. 3 responses were ongoing at the time of publication. All 3 responders have developed adrenal insufficiency. Notably, responses were observed in patients without the traditional biomarkers of response to immune therapy, with responses seen in patients with low tumor mutational burden, low PD-L1, and absent TILs. Finally, the Artemis trial, published in part this past summer, has provided us with important tools which we could use to further study metaplastic breast cancer. This trial looked at triple-negative breast cancers in the neoadjuvant space and prospectively identified 39 patients with metaplastic breast cancer. Patients received neoadjuvant adriamycin and Cytoxan for 2 cycles, followed by an on-treatment image-based response assessment. Following AC, responders continued to receive standard of care therapy, while non-responders received tumor-targeted therapy based on an on-study biopsy. Patients with metaplastic breast cancer had higher rates of tumor progression on AC than those with triple-negative breast cancer NOS, and 2 of the 39 patients with metaplastic breast cancer developed metastatic disease while on neoadjuvant therapy, relative to 1 of the 172 patients in the triple-negative cohort. This study has several important findings. First, for metaplastic breast cancer, PCR rates were improved above historic levels. Artemis reported a pathologic complete response rate in metaplastic breast cancer of 23% in 39 patients. As a reminder, previously reported PCR rates in metaplastic breast cancer are shown on the left. Second, Artemis also found that, as with triple-negative breast cancer broadly, PCR correlated with improved survival in metaplastic breast cancer, shown in the figure on the right. Also, we are seeing here that while some agents are effective, there is no single home run, likely in part, again, due to the heterogeneity of this disease. Reports of exceptional responses to novel therapies in metaplastic breast cancer are increasingly observed. Responses have been observed across a wide variety of agents and across a spectrum of metaplastic histologies, again, likely pointing to this disease's heterogeneity. One might envision that an important part of the road for success here will be the ability to predict in advance which therapy will work for an individual patient. Or it is tempting to think that there might be a more all-encompassing option. Could antibody-drug conjugates or other emerging drug classes have more widespread applicability? Hopefully, we'll get more information on this at upcoming meetings. Metaplastic breast cancer is, generally speaking, an aggressive and highly heterogeneous disease, where information has come largely from retrospective series and case reports. However, We may be at a tipping point where our opportunity to use emerging technologic tools on several fronts can advance our knowledge in this space, hopefully rapidly. Trials in metaplastic breast cancer and other uncommon tumors have been difficult to conduct for a variety of reasons. The relatively small number of patients, will individual sites open and operationally these trials which enroll only occasional patients? Finally, promising new agents are critical in this space, but will the smaller n make these less attractive to our industry partners? There have been successes which we could perhaps build upon, such as the DART study or the work of NRG, GOG Legacy, which has a remarkable track record of NCTN trials in the space, though most trials have been single-arm and required international collaboration. Perhaps there are also opportunities here. We could support international efforts. Could we look towards our networks, which enrich for our megacenters where many of these patients are seen? Throughout our field and at this meeting, we're hearing about exciting emerging new tools that could have activity in breast cancer. Survival gains in breast oncology in the next decade will rely in great part on improvement made for the patients at highest risk, including those with metaplastic breast cancer and those that my colleagues today will be talking about. So promising new therapies in this space are really exciting. So in a perfect world, what would a trial look like in metaplastic breast cancer? How might we target the diverse disease vulnerabilities of metaplastic breast cancer as we seek to improve outcomes for our patients? When considering disease space, intervention, trial design, and feasibility, this is an outline favored at a recent retreat. This proposal would have patients receive upfront chemotherapy with checkpoint blockade, followed by response assessment, with responders continuing on for standard of care, and non-responders receiving therapy based on molecular features of an on-study biopsy. This design has features similar to the Artemis trial and the I-SPY trial. Well, regrettably, it's not yet a perfect world, so as we work to develop these trials, how else might we gain disease-specific knowledge? Many trials, particularly those looking at triple-negative breast cancer, allowed for enrollment of patients with metaplastic tumors, but did not prospectively identify these patients. Listed here are recent trials in this space. Can we retrospectively mine these trials for information? We would likely find valuable, even randomized information here. Many of these trials enriched for high-risk triple-negative breast cancers and could easily have a meaningful N. The real challenges to retrospective review exist, including that the pathology, even just the reports, may not have been collected. So what about prospectively? Can we prospectively identify patients with metaplastic tumors as we open new studies and move forward with our platform trials? We could perform full cohort analyses and, in addition, conduct pre-planned analyses on less common tumors, such as metaplastic breast cancer. This will require some upfront work and engagement of our pathology colleagues. However, modern technology, including virtual pathology, could make this less costly and more feasible than in earlier eras. Is this something we can ask of our federally funded trials, as this may well be a space that our industry partners may not look for answers. And as virtual pathology transcends borders and would perhaps have a lighter regulatory burden, could pathology be incorporated into our international studies? I'm delighted to report that we have embedded prospective pathology into I-SPY 2.2. This has been complex to put in place, and likely as it is operationalized in the coming months, will be further refined. Allow me to walk you through our initial process. In this platform trial of neoadjuvant therapy, there are multiple time points on which a patient could have a tumor identified as an uncommon subtype. At baseline, on-study biopsies, or at surgery, shown in light gray. Initial pathology pre-enrollment is not necessarily reviewed by an I-SPY pathologist now. However, now at least all reports will go to a central team for review, with uncommon tumors flagged for central histology review. At another on-study pathology time points, an uncommon tumor could be flagged by any team member, including the local I-SPY pathologist. These cases are then forwarded for central review, ultimately leading a cohort of patients with uncommon tumors for outcome sub-analyses. Though this process will almost certainly need to be further refined, the potential for robust information is enormous and includes enhanced understanding of response predictive subtypes and outcomes data. Another highly promising technological tool in this space is real-world data. Real-world data can have applications in rare diseases when clinical trials are impractical. One example of such information is how we can address questions in less common breast cancer presentations includes the utilization of real-world data to support a label expansion for palbociclib in men. Could real-world data give us more robust information on metaplastic breast cancer? At one level, real-world data could provide retrospective information on outcomes of patients with uncommon tumors, which could be valuable and offer larger and more contemporary data sets than we've historically had. But can we go further? Could a new paradigm in data curation allow for the real world to become the clinical trial? In this model, centralized retrospective data collection with electronic health record capture would seamlessly integrate with prospective intentional data capture on selected trial periods. One example of intentional data capture could be outcomes for patients with HER2-low metaplastic breast cancer who receive antibody-drug conjugate therapy. Let's look at this another way. Could we prospectively identify patients with rare tumors such as metaplastic breast cancer through the electronic health record? Could we then pool these patients and use sophisticated EHR tools to intentionally capture data associated with specific interventions? Clearly, we would use this tool for lower risk interventions, at least initially. However, as a newer, powerful tool to study uncommon tumors, this could bring us more meaningful information than we've had in the past and could expand study access, overcome barriers inherent in small study sizes, and perhaps offer global applications. I'm going to dream here for just a little bit at the end and ask, could we add to this and incorporate another technologic tool, artificial intelligence, to read histology which we electronically incorporate into the medical record? This would allow us then to group cohorts of patients with uncommon tumors and study their outcomes, either with observation or pre-specified interventions. This would improve our confidence in the tumors that are represented in a cohort, as well as reduce registration issues and inter-observer variability, these have been challenges for the studies of uncommon tumors heretofore. And again, could this eventually make global applications more feasible? Thank you for going down this road with me this afternoon. To review, key take-home messages are: metaplastic breast cancer is seen with some frequency in the clinic. Prognosis for metaplastic breast cancer is currently inferior to that of most other breast cancers. Enhanced molecular understanding of metaplastic breast cancer and newer therapeutic options provide reason for great optimism. Newer research tools which harness technology and allow us to pull out patients and study them through the EHR could offer promise of further disease-specific understanding. I'd like to thank you for your attention this afternoon.
Thank you, Dr. Thomas, for a wonderful overview. Now we're going to change the gear to inflammatory breast cancer. I know that some of you, especially, we get a lot of questions about metastatic plastic breast cancer, but we can save the questions at the end, and we're going to have more panel discussion and answer. The next wonderful speaker is Dr. Philippa Lins, who is an assistant professor in the Dana-Farber Institute and also a director of the inflammatory breast cancer, very dynamically organizing a lot of translational projects between triple-negative breast cancer and inflammatory breast cancer, and she's going to show us the IBC perfect storm.
Thank you, Dr. Lim. Can you hear me well? So I'd like to start by thanking the organizing committee for inviting me to be here today to talk about inflammatory breast cancer. Here are my disclosures, and here is the outline of what I plan to cover over the next 20 minutes. So inflammatory breast cancer is a distinct clinical pathological entity defined by the AJCC 8th edition as clinical T4D, and it requires a diagnosis of breast cancer along with some typical clinical findings that usually includes erythema and edema of the skin of the breast. It's characterized by an incidence of about 1 to 5% of breast cancers with a disproportionate high rate of mortality. It presents more often with de novo metastatic disease when compared to non-IBC, has a higher prevalence of brain metastases and HER2 overexpression, estimated to be about 35%. To date, no specific driver mechanism has been identified. We also know that obesity is a risk factor in postmenopausal women, but also in premenopausal women, and we know that IBC affects disproportionately young women and African Americans. Also, ambiguity in the diagnosis is an issue that we'll need to tackle. So dermal lymphatic involvement has been a pathological hallmark of IBC. About 75% of the patients with IBC have presence of dermal lymphatic invasion, that is thought to be associated with an increased number of metastases to the lymph nodes. However, dermal lymphatic invasion alone is not sufficient, neither necessary to define IBC. We also know that there is overexpression of icadiran, thought to be to play a role in the tumor cell to tumor cell connection. However, there are cases of IBC of lobular histology, as we just heard, that do not have icadiran, so a very important point as well. So historically, we have been told that the outcomes of IBC are poor, and this is shown here in SEER analysis, showing that the overall survival of patients with IBC are inferior compared to locally advanced breast cancer. This data, however, is almost 20 years old, and we have made progress over the last 4 decades. As you can see here on an updated analysis from the SEER databases, the mean survival time went from about 48 months for those diagnosed in the early 70s to doubling to 99 months for those diagnosed more recently. In the metastatic setting as well, patients diagnosed with inflammatory breast cancer have worse outcomes, and this is data from the National Multi-Center French cohorts, where they showed us that with a median follow-up of 15 months, the overall survival for patients with metastatic IBC was 28 months, when compared to 37 months for those with metastatic non-IBC. So what we know about signaling pathways and genomic alterations in IBC? So as I mentioned, we haven't been able to identify yet the specific pathway for IBC. However, there has been a lot of work trying to understand molecular alterations that are seen in IBC tumors. And I just highlighted here some of them in this cartoon, and it includes the RBB family members, the angiogenesis and JAK-STAT pathway, and members of the tumor microenvironments. And if we understand better what is the role of these, as well as how the IBC cells depend on these, we might be able to design clinical trials that try to take advantage of these pathways. And I just included here some clinical trials that have been recently completed or are undergoing that try to explore some vulnerabilities of inflammatory breast cancer. In the next few slides, I'll just highlight some of the preclinical data related to the JAK-STAT pathway and the role of macrophages in inflammatory breast cancer. So we know that IBC contains a significant component of CD44 positive, CD24 negative cells, known to have a stem cell or progenitor-like properties. And you can see here illustrated on your right in immunofluorescence looking at CD44, CD24, and STAT3, and this is of IBC samples, that there is a high representation of CD44 positive, CD24 negative cells. I show you here on the left lower corner the percentage of phospho-STAT3 positivity according to each of these 4 cells per tumor subtype, and you can appreciate that there is an increased percentage of phospho-STAT3 positivity in CD44 positive, CD24 negative cells, in particular in the triple negative and ER positive subtypes. Work done by Dr. Nelly Polyak from Dana-Farber and others has shown that activation of the IL-6, JAK2, and STAT3 pathway is required for the growth of CD44 positive, CD24 negative cells in breast cancer, and there is ongoing work to try to understand what is the best way and the best drug to target this pathway. We've heard wonderful talks during this meeting about the role of macrophages in breast cancer and how we might be able to target those. I show you here that the infiltration of macrophages is different in breast cancer compared to normal breast tissue, And you see on your left, IHC stain for CD68, a human macrophage marker showing dense infiltration of macrophages in breast cancer cells. And on the right, I show you in these Kaplan-Meier curves, here the increased macrophage density highlighted in green, that these patients experienced worse relapse-free survival and overall survival. But what do we know about macrophages in inflammatory breast cancer? I highlight here some of the important work that has been published in the last years, coming from different centers, coming from Dr. Wendy Woodward from MD Anderson and her colleagues, coming from Dr. Devi from Duke and colleagues at the University of Antwerp, and coming as well from colleagues at NYU. So there is a lot of work that has been done in this field. On the right, I show you results of 23 patients that participated in a HER2-positive inflammatory breast cancer trial at our center. These patients underwent a biopsy on day 8, and it showed that patients that did not achieve a PAT-CR compared to those who achieve a PAT-CR had a higher percentage of macrophages and a lower percentage of T cells. There is work undergoing, being done by Dr. Guerrero and colleagues to trying to understand the phenotype of these macrophages and whether they played a role in this decreased infiltration of the tumor by the T cells. And what do we know about specific transcriptomic findings in IBC? There's also been a lot of work done in these fields, and I just highlight here some of those publications. On the right, I show you a volcano plot that was, this research was conducted by Dr. Van Leer and colleagues, and he showed us that there was differences in the gene expression when you look at untreated non-inflammatory IBC and IBC. Here in particular, he showed overexpression of TGF-beta induced in IBC when compared to non-IBC. More recently, investigators from MD Anderson and Yale look at 20 IBC tumors, and they compared the results of whole gene sequencing with data from 23 non-IBC tumors from TCGA that were matched for ER, PR, HER2, age, and race. And what they found was that there were no significant differences between IBC and non-IBC in terms of the overall mutation loads, genomic heterogeneity and mutation signatures, as well as somatic structural variants. However, they showed that the number of germline structural variants was higher in IBC as compared to non-IBC, specifically related to TGF-beta pathway. So more work needs to be done in these fields. So I just show you that some of the characteristics of IBC have to be addressed, and I highlighted here what I feel that in my perspective might be opportunities to improve the outcomes of patients with inflammatory breast cancer. So let's start by improving the diagnosis of inflammatory breast cancer. So an IBC task force was put together a couple of years ago with the goal of trying to improve the diagnosis of inflammatory breast cancer. And you can see here that the proposed scoring system relies mainly in clinical characteristics and secondarily on the presence of lymphatic emboli and breast imaging findings. Each of these characteristics was given a priority factor based on its importance. If you look at the manuscript that was led by Dr. Jagzi and Dr. Miller, where they explained the development of this proposed scoring system, it also includes photographies that illustrate some of these characteristics and try to include different skin tones. So proposed scoring thresholds were recommended based on the total scoring after adding all the variables. And you can see here the 4 categories that go from definitely IBC to not IBC. Now, this new proposed scoring system needs to be validated, and recently Dana-Farber and MD Anderson received the grants from the Milburn Foundation, Susan G. Komen, and Inflammatory Breast Cancer Research Foundation to try to validate this scoring system through the combined analysis of our IBC databases. And we are very fortunate to collaborate with Dr. Meredith Regan, that is the statistician in this project. If this scoring system is validated, one can argue that we could use the two top categories for trial enrollments in IBC dedicated trials. So what about pathological complete response in IBC? Well, we know that pathological complete response, and let me just move forward. Okay, I'll start by this and then I'll go back. We know that pathological complete response in breast cancer in general is associated with outcomes. Dr. Naklis and other authors have looked at the role of pathological complete response and prognosis in inflammatory breast cancer. I show you here her work. She looked at 181 patients with stage 3 inflammatory breast cancer that were seen at our program. And what she showed was that achieving a PAT-CR was associated with improved time to recurrence and overall survival. So let me just go back and now show you this table that I put it together to try to summarize the PAT-CR rates that have been reported either on single institution databases or the National Cancer Database or clinical trials that were dedicated to IBC. And just historically, the PAT-CR rate in IBC has been described as being lower compared to patients with non-IBC. Here I show you, highlighted in yellow, these results for patients with triple-negative IBC, and you can appreciate that the pathological complete response was below 20% in the vast majority of the trials, although this does not reflect the use of immunotherapy in the neoadjuvant setting yet. There was an outlier that was a study conducted by Dr. Ueno when he was at MD Anderson with 19 patients where he showed a PAT-CR of 42% using panitumumab, an anti-EGFR antibody, in addition to chemotherapy. And this concept continues to be developed in a new phase 2 trial at MD Anderson, where the investigators added pembrolizumab to this combination. In ER-positive, HER2-negative, the PAT-CR rate has been reported as anywhere between 6 and 19, and even lower for those with ER-positive, HER2-low. And in HER2-positive, the PAT-CR rates have been more encouraging, in particular if you have in mind that many of these patients did not receive dual HER2-targeted therapy as neoadjuvant treatments. So the way that I wanted as well just to highlight one trial of what I showed you, that is a trial that was conducted and led by Dr. Overmoyer at Dana-Farber that included 23 patients that received 1 dose of trastuzumab and pertuzumab, followed by 16 weeks of paclitaxel, trastuzumab, and pertuzumab, with a PAT-CR rate that was the primary endpoint of 43%. So the way that I look at this is, although we are not ready for this yet, in the future, patients with HER2-positive IBC might be an opportunity to de-escalate if we are able to identify who are these patients able to do well with a less toxic regimen, and we are working with Dr. Elish Pratt to try to answer this question. So the way that I look at this is that HER2-positive IBC and triple-negative IBC are different in the ways that they compare to outcomes in breast cancer overall or with non-IBC. So we have HER2-positive IBC patients. They have very good outcomes. You can see here the patients that have a PAT-CR do extremely well. And you can see on your right data that Dr. Garrido Castro from Dana-Farber presented at San Antonio 2 years ago. She looked at 78 patients with de novo metastatic HER2-positive inflammatory breast cancer and showed that the median overall survival for these patients was 4.6 years. And have in mind that only 60% of these patients received upfront dual HER2-targeted therapy, so it's a different patient group from the investigational arm in Cleopatra. On the other hand, we have our patients with triple-negative IBC that in general do very poor. You can see here that the PAT-CR, the outcomes of patients that achieve a PAT-CR and have triple-negative IBC, are similar to the outcomes of patients that do not achieve a PAT-CR and have ER-positive, HER2-negative, or HER2-positive disease. And the patients that do not achieve a PAT-CR and have triple-negative IBC are those with the worst outcomes. You can see similar data on your right, single institution analysis of a database from Marseille in France. And this is all patients with stage 3 IBC. And what you can see here is that the 5-year overall survival is reported to be 52% compared to the 5-year overall survival of 80% for patients with locally advanced breast cancer. So to summarize this first part, systemic therapies used in inflammatory breast cancer have been the same used in non-IBC. When we see improvements in clinical outcomes in breast cancer in general, we see improvements in IBC, and that was demonstrated by the most recent SEER database analysis that I showed you. So it seems that the best way to make improvements in IBC is to continue to develop better therapies, and this is what I'll cover in the last few minutes of my talk. Perhaps the best strategy is to look at drugs that showed promising efficacy in the metastatic setting and try to move it to the early setting for stage 3 inflammatory breast cancer. So we all have shown the impressive results both of DESTINY-Breast03 and ASCENT that led to the approval of trastuzumab deruxtecan and sacituzumab govitecan for the treatment of advanced breast cancer. So here are two concepts that we recently developed, combining antibody-drug conjugates with checkpoint inhibitions based on preclinical data that showed an important role of the tumor microenvironment in inflammatory breast cancer and perhaps an increased expression of PD-L1 positive in these tumors. So we decided to combine these two antibody-drug conjugates with checkpoint inhibitors for patients with stage 3 inflammatory breast cancer. So here is the first trial, TRUDY, that we opened that we hope that will be open for enrollment in the next few months. These will include patients with stage 3 IBC that can be enrolled in one of two cohorts, either HER2 positive or HER2 low. Patients will receive 8 cycles of trastuzumab deruxtecan and durvalumab with primary endpoints of PCR. This trial is being led by Dr. Tarantino and myself at Dana-Farber with our collaborator, Dr. Ueno and Dr. Lehman, who will be the PI at MD Anderson. We recently looked at the prevalence of HER2 low in inflammatory breast cancer. Dr. Tarantino looked at 276 patients with HER2 negative IBC. We found that the distribution of HER2 low and HER2 zero was similar to breast cancer in general. And when we looked at invasive disease-free survival, although it seems that the patients with HER2 low IBC did better than those with HER2 zero, similar to the breast cancer in general, what we found was that when you look at these curves by ER status, ER positive, ER low, or ER zero, the curves really overlap. So it seems that the differences in outcomes are being driven mainly by the ER status and not by HER2 low versus HER2 zero, and this is aligned with the discussion that we heard yesterday. So the last slide that I want to show you is this trial. So we developed an arm within the NeoStar, a trial led by Dr. Bardia and Dr. Spring from MGH, and we suggested to conduct this arm just dedicated to IBC patients, where we look at the PAT-CR of sacituzumab govitecan with pembrolizumab, followed by AC with primary endpoint PCR as well. So to conclude, different IBC subtypes are associated with different outcomes and compare differently to breast cancer in general. Better systemic therapies are likely to lead to better outcomes in inflammatory breast cancer, and improved diagnostic criteria may lead to better patient identification and research efforts. So I would like to thank to all our patients and their families, each of the members of our Dana-Farber Inflammatory Breast Cancer Program, and our external collaborators, our funding agencies and partners, as well as families dedicated to end inflammatory breast cancer. And I would also like to thank Dr. Halberstein and Dr. Paulo Tarantino for their thoughtful inputs on my presentation. Thank you.
Thank you for the wonderful presentation about the IBC. The last but not least, Dr. Sibyl Leubel, which we met in the many podium for landmark trials and clinical trials lead. She's the actual chair of the German breast cancer group. And so that's one of the reasons why we're very honored that she's gonna have a actual overview in the slightly different topic that we think that we know, but maybe not so, of the lobular and pleomorphic carcinoma of the breast.
Thank you very much for the introduction. Good afternoon, everybody. I hope I don't take that personal that everybody is leaving now, but I think we are closing to get the 5 o'clock. So these are my disclosures. I will be speaking as indicated about the lobular carcinoma, and you have already heard a lot about lobular carcinomas and the pathological part from the first speaker. We know that invasive lobular carcinoma is not a really rare subtype. It's the second most common subtype, and it's about 10 to 15% of invasive breast cancers, depending on the cohorts you look at. The rate increased actually from close to 10% to the 15% in the years when a lot of hormone replacement therapy has been used, but it did not decrease really thereafter when the use of HRT became less common. We have observed that there is a higher incidence in white women, and there is a subgroup of the lobular carcinomas you have heard before. This is the pleomorphic lobular carcinoma, which is about 15% of the lobulars and about 1% of all breast cancers. So how does invasive lobular carcinoma evolutionize? So we have a normal cell, and we know that there are atypical lobular hyperplasia and some sort of lobular carcinoma in situ, which are not, in contrast to ductal carcinomas, obligate precursor lesions. They are associated with about 7 to 10 times higher risk of developing unilateral but also bilateral breast cancer. You have heard about the E-cadherin loss in lobular carcinoma, and E-cadherin is a binding protein, and with the loss of E-cadherin, there is an epithelial to mesenchymal transition of these cancers. And mutations, as you had heard in the first speaker, play an important role, and mainly the CDH1 gene, loss of the gene, which is account from the E-cadherin loss, and also other mutations I'm coming to in a second. And we have different subtypes of the lobular carcinomas, from the classical one to the alveolar one to the solid one, tubular lobular ones, and pleomorphic ones, and you have heard that from the pathologist as well. So I have no pictures because I'm not a pathologist. So what about the genomic alterations? We have already heard the CDH1 is the most common one, and it accounts about 65% in lobular cancer or even higher. And the TCGA dataset looked at that in comparison to the invasive ductal carcinomas, where it's very rare, and it's a bit more often, of course, in the mixed lobular ductal subtypes. But next to the second common is already the PI3 kinase mutation with over 40%. And when you look at the whole signaling pathway from PI3 kinase, AKT, and PTEN pathway, then this accounts for about 50% of the genomic alterations. And we have heard in the morning an AKT inhibitor where we could use this drug, and lobular cancer where we have more than in all other cancers might be a candidate for that in the context, because this is a targeted mutation. We also see that some of those mutations are associated with a certain breast cancer-free outcome, and the HER2 and AKT mutations are associated with an increased risk of an early relapse. And the chromosome alteration, the IQ and 11p gain of the function and loss of mutation are have independent prognostic value in the invasive lobular carcinomas. So on panel E, you see, I can't read that really here, the 11p, and on the right side, you the 11q, and they have an opposite direction. So you have seen this picture before. I'm not going into detail again. I just want to mention that the clinical pathologic variables are associated with certain genomic alterations, and the picture is also different of the invasive lobular carcinoma depending on the certain and the different mutations you have. Targetable alterations are important. I have already outlined the PI3 kinase alterations. They're also important in invasive pleomorphic lobular carcinoma. And there is a high frequency not only of the PI3 kinase mutation and alterations, but also of the ERBB2 mutation in pleomorphic lobular carcinoma, which have also a certain implication maybe for treatment decision making. The mutational landscape of invasive lobular carcinomas in primary and metastatic samples is outlined here again, and the most common are the CDH1 for eCatherine, and of course the PI3 kinase mutation. And this comes up in all investigations which have been published. And as you have heard, some of them are associated, some of the genomic alterations are associated with endocrine resistance and might play a role in today's modern treatment options. And when we look at the invasive lobular carcinoma, we might consider testing those patients even more often, because we will find more mutations and also more mutations that play a role in the endocrine resistant pathways. So what other characteristics, apart from these molecular types, are associated with invasive lobular carcinoma? We know that the patients are usually older at the first presentation. They are very frequently quite large, multicentric and bilateral, and they're more difficult to detect at imaging, and that's with a higher rate of false negativity at mammography. And that's also the reason why we see more larger stage, more nodal involvement at the time of first presentation. The classical ILCs, these are the ones associated with high expression of hormone receptor positivity and HER2 negativity. And already heard the eCatherine negative. That doesn't mean that you need to stay in, and I hope the pathologists agree that you need to stay in all cancers, all breast cancers for eCatherine to look for the lobular ones. High nodal stage and nodal involvement already touched, and we see more frequently metastasis to the gastrointestinal tract, the ovaries, the peritoneum, and the bone, and see less lung metastasis, and this plays a role when we treat metastatic lobular carcinoma. In contrast to the more classical type, the pleomorphic invasive lobular carcinoma are also associated with the postmenopausal status, the older age, and they're more likely to be HER2 positive. What is the prognosis of lobular carcinoma? One could assume, because of the high hormone receptor positivity and the HER2 negativity, they have a very good prognosis. And this is the case in the first 5 to 6 years, but thereafter it turns around. And this a very elegant analysis with a very long follow-up of over 20 years demonstrate that after the year 6, year 10. On the right side for overall survival, the prognosis changes, and thereafter the lobular carcinoma tend to have a worse prognosis. And this is also true when we look into the subgroup by hormone receptor positivity, and on the left in the table you see the disease-free survival. On the right side you see the overall survival, and in general after 6 years for disease-free survival the hazard ratio turns to over 1, indicating a higher risk for the hormone receptor positive as well as for the hormone receptor negative invasive lobular carcinomas, and the same is true on the right side for the overall survival. More recent studies looked at the different outcome for overall survival and breast cancer specific survival for lobular versus ductal invasive carcinomas. And because the follow-up is very short, or is much shorter, we don't see this crossover maybe yet. And I think we should encourage to have a longer follow-up in this very large series where we might detect even better rates. But here the first years indicate, as in the previous analysis, better outcome for the invasive lobular carcinomas in contrast to the invasive ductal carcinomas. What about pleomorphic carcinomas? Because they are higher grades, more often HER2 positive, they are probably associated with a worse prognosis. This is a small series indicating, in fact, that the pleomorphic lobular carcinomas do slightly worse than the classic lobular carcinomas, but the numbers are small and we need to be careful here. We also see not only pure lobular carcinomas, very often we see mixed type of ductal and lobular carcinomas. And this is an analysis from the Big 198 study looking into the disease-free survival for the lobular versus the mixed population. And you see on the left side that the mixed population does better overall, but this is different according to the menopausal status. Why you see in the smaller group, of course, of premenopausal patients, no difference. On the right side, you see a difference in the postmenopausal patient in favor of the ductal lobular carcinomas. So how do we treat lobular carcinomas? Do we treat them really differently from ductal invasive carcinomas? Should we treat them differently? What data do we have? So let's start with the neoadjuvant chemotherapy invasive lobular carcinomas, because they are very often large nodal involvement, so we tend to use chemotherapy or neoadjuvant treatment here. This is an analysis from our own data set, where we looked at more than 1,000 lobular carcinomas and compared to 8,000 ductal invasive carcinomas or non-ILCs, where we grouped the all non-ILCs, what was reported from the local pathologist. And overall, we saw, of course, a significant difference in terms of PCR rate achievement, which was significantly lower, only 6% for the lobular carcinomas compared to the ductal invasive carcinomas. But when we split them according to the hormone receptor stages and the grading, then it becomes quite clear that the pure lobular carcinomas that we call the classical ones, they achieve only a PCR rate of 4% with chemotherapy, but the more aggressive they are, hormone receptor negativity and grading on the right side, which is only a small number of the patients, then we achieve PCR rates of close to 18% in this analysis. We looked also further on the outcome. Does the neoadjuvant chemotherapy have an impact how we operate lobular carcinomas? Because we tend to do more mastectomies, and we still do more mastectomies here. You see on the lower part the invasive lobular carcinomas with PCR and no PCR, and the mastectomy rate is quite high with 75% still in the PCR cohort and over 80% in the non-PCR cohort. And this is driven by stage and nodal involvement, where in the top part you see the non-ILCs, where the mastectomy rate is significantly lower, and other factors like the response do have an additional impact in how we treat and operate the patients. What about the long-term outcome, local recurrence-free and distant disease-free survival? Here the PCR versus non-PCR analysis. And the PCR patients do best in this cohort, but only in the non-ILC, the lobular carcinomas, when they achieve a PCR, do not really better in terms of distant disease-free survival, while there is not a big difference in the local recurrence-free survival. And in terms of overall survival, the PCR patients group nicely. On top we see the two PCR cohorts, the lobular and the non-lobulars, and below we see the non-PCR curves grouped together for the lobular and non-lobular patients. So we only see a difference in the distant disease-free survival, where the PCR apparently doesn't impact so much, but the long-term follow-up is not as long as we have, not 20 years as we have seen before. So there is a meta-analysis also looking at the PCR rates in ductal versus lobular carcinomas, and you see the blue dot on the right side, which indicates a higher PCR rate across all those trials for the ductal invasive compared to the lobular invasive carcinomas. Numbers are small, but also the axillary PCR, where there have been fewer literature reported. You see a higher rate of axillary downstaging for the non-lobular carcinomas compared to the lobular carcinomas. But numbers, as you see, are again small. That's why a meta-analysis is probably the preferred way to go. So how do what has been seen in the meta-analysis according to the breast-conserving surgery? And again, more mastectomies are done, or more breast-conserving surgery is done in non-lobulars compared to the lobular carcinomas, and there are also more often positive margins and re-excision in the lobular cancers, even after neoadjuvant chemotherapy in those patients in this meta-analysis. Here in this analysis, the overall survival for the lobular carcinomas with the ductal invasive carcinomas according to PCR was not different. So how do we transport those findings from the neoadjuvant chemotherapy to the recommendations? And this is from the German guidelines. And you see here on the low bottom we have the metaplastic tumor type and the lobular tumor type. They have a lower PCR here in this setting, and because there are meta-analysis, the level of evidence is high, and this can be used as a predictive factor for PCR, as a negative predictive factor for PCR, but I don't think this is such an important factor in lobular carcinoma to achieve a PCR. When it comes to downstaging, we still need to think if it makes sense to use a neoadjuvant chemotherapy. This is a trial where in lobular carcinoma, where they investigated the combination of a platinum agent and atezolizumab for the lobular carcinomas, and the trial was stopped because there was no sufficient benefit seen in this patient. I didn't show you the TIL data and the from the analysis before, but the TILs are not very common here, but they didn't see any difference in terms of PDL high or low patients. So what about neoadjuvant endocrine therapy? I apologize, this is a busy slide, but actually what it tells you that there is no really there are lobular carcinomas in these neoadjuvant endocrine therapy trials, but they didn't really look at the lobular carcinomas, and there are lobular carcinomas included, but unfortunately we have to take what has been seen in this neoadjuvant endocrine therapy as a result for the lobular as well as the ductal carcinomas. But we might need to look in the future more into the results specific by the subtype to learn more about how to treat those patients. What about adjuvant chemotherapy in invasive lobular carcinomas? There are several trials, and they showed mainly similar results between invasive lobular carcinomas in the outcome compared to the invasive ductal carcinomas in these trials. You see here on the right side the overall survival data at 10 years, and there is no really a big difference for those patients after chemotherapy. The impact of adjuvant chemotherapy on distant disease-free and overall survival is outlined here again in a quite nice series, and the patients with lobular carcinoma benefit from the addition to chemotherapy to endocrine therapy if they are large and have nodal involvement in this cohort, and they looked at a matched cohort and they saw the same difference in favor of adding chemotherapy, and this is probably true for patients with high nodal involvement and large tumors. For overall survival, we see here the same results, a benefit in terms of chemotherapy. So the impact of adjuvant chemotherapy is further looked at here in this summary of the slides. So you see at the bottom in the table the low-risk group with chemotherapy and without chemotherapy. There is not a real benefit, but in the high-risk group, as I mentioned, there is a benefit for using also chemotherapy in addition to endocrine therapy for lobular carcinomas. What about adjuvant endocrine therapy in invasive lobular carcinoma? I think this is probably the most interesting part because there have been mixed results from various large adjuvant endocrine trials. Whereas in the TEAM trial looking at exemestane versus tamoxifen followed by exemestane, there was no difference in terms of outcome by the histological type lobular versus non-lobular carcinoma. In the MA17 trial, also using exemestane versus anastrozole, there was also no difference in terms of invasive, the ductal carcinoma on the left and the lobular carcinomas, on the right side. But the Big 198 trial was the first trial indicating that there might be a higher benefit for an upfront aromatase inhibitor in patients who have a lobular carcinoma. And you see here on the left side, the dotted lines are the lobular carcinoma and the solid lines are the ductal carcinomas. And you see here a big difference between I have here the lobular carcinoma with the aromatase inhibitor, and here the lobular carcinoma with tamoxifen. Tamoxifen in terms of the disease-free, and on the right side in terms of the overall survival, there's a grouping more for the ductal invasive carcinomas. They looked at the luminal A versus the luminal B-like carcinoma. This was the difference we see was mainly true for the luminal B-like carcinomas here and here, especially. There is also a difference for the ductal carcinomas, but the luminal A-like we only see the difference in terms of better outcome with an aromatase inhibitor for the lobular carcinomas here, where the ductal carcinomas do not have don't show a difference, and this is seen in this forest plot a little bit more clearly. We have the ductal carcinomas here. Luminal A-like do not benefit from using an aromatase inhibitor, but the luminal B-like do. Whereas in the lobular carcinoma, luminal A and luminal B-like you benefit from using the aromatase inhibitor. And this was for a while thought to be the standard of care. We need to use an aromatase inhibitor for lobular carcinomas, and it was actually the first treatment decision made based on the histological subtype for the patients. The study which did not repeat these results was actually the ABCSG8 trial, where the patients were randomized to tamoxifen or the sequence of tamoxifen followed by anastrozole, and in the overall cohort there was no significant difference. You see here the hazard ratio in terms of lobular versus ductal carcinomas for disease-free and overall survival. They also looked at the at the luminal A and B subtypes. And in fact, in the luminal B subtype, they saw a difference, a larger benefit for the lobular patients treated with an aromatase inhibitor for the disease-free, but not for the overall survival, if I see that correctly. So what are the ongoing studies? This is the last chapter for invasive lobular carcinoma. Can we treat them differently? Well, we need to see that. We don't have so many different treatment options here. There are a couple of phase 2 and 1 phase 3 trial investigating different endocrine and endocrine-based options. Here are a ROS1 inhibitor, a CDK4/6 inhibitor in the Penelops trial, and an IA insert in the alternate trial for basically hormone receptor positive, HER2 negative breast cancer patients with lobular subtyping. I have already spoken about the Gelato trial and the Rollo trial with E-Catherine negative or a CDH1 mutant, ER positive patient, triple negative patient. They use a crizotinib in combination with fulvestrant. And this study in hormone receptor positive, HER2 negative lobular carcinoma look at the SERM versus II and a SERT and the change in Ki-67. This is still recruiting, and the Gelato trial has been stopped in the advanced setting. So in summary and conclusion, ILC invasive lobular carcinoma is a distinct subtype of breast cancer. It's a logical subtype. The majority of them, the classical ones, are hormone receptor positive and HER2 negative. ILC harbor more often somatic mutations, especially from the PI3 kinase pathway, up to 50%. And I think we need to when we think about testing, we might think testing the lobular carcinomas first because we have a higher chance to find a targetable mutation here. The pure lobular carcinomas respond poorly to neoadjuvant chemotherapy and should not be offered neoadjuvant chemotherapy routinely. And the lobular carcinomas might benefit from an AI upfront, especially the luminal B subtyping, because here we saw consistent results, whereas in the luminal A subtyping, this could not only be demonstrated in the big 198, and it's less clear. So I would like to acknowledge everybody who works with GBG, the GBG team, and all the colleagues from pathology, where I learned a lot in recent years, and from the other labs, and of course all the families and the sites who participate in our trials, and the GBG support team sends you. Wish you Merry Christmas and Happy Holidays. Thank you.
Okay, so the next session is going to be the poster highlight. So we may have a little bit of time, like 5 to 7 minutes to have questions. Please come to the podium or post your questions in here. If not, you can also DM us in the Twitter. In case. NABORALA. Yeah, okay, there's a questions.
So I thought, I'm Susan Tannenbaum, University of Connecticut. I thought I'd ask the thought leaders how they would manage a rare presentation of a rare cancer. So I have a 42-year-old BRCA mutated patient who had bilateral mastectomies and was found to have an adenoid cystic cancer. It was a solid cancer, and it was high grade, triple negative. So how would you approach this? It was a 2.5 centimeter tumor. These have more problematic prognosis than the ones that you talked about before. So just...
Excellent question here. We have to bear, so you're describing adenoid cystic in the context of a BRCA2 pathogenic germline variant. If we had a case like this, we would discuss it at the molecular tumor board, ascertain if the tumor, because for instance, we do MSK impact sequencing in all of our samples of this nature. So we would ascertain whether there is biallelic inactivation of BRCA2, and if the tumor would have features of HRD for us to establish a causal link between the BRCA2 mutation and this tumor type. Because more often than not, But there are always exceptions in biology. But as a rule of thumb, these tumors would not be linked to BRCA2 germline mutations, an adenoid cystic. Now, a tumor that can be a differential diagnosis in this context, that can be BRCA2 mutated, is the actinic cell carcinoma of the breast. The actinic cell carcinoma. It's vanishingly rare, but Stuart Schnitt's group and our group have found quite a few cases of actinic in the context of a BRCA2 germline mutation.
So for the clinicians, would the type matter in terms of how you would manage this patient?
Now, I was telling Dr. Rice-Filo the first thing I would do is get a good pathologist to make sure that that pathology was what I agreed with, and I agree with him. It may not be. I would probably be sending it out for some of the questions that,
Okay.
before I could decide on treatment.
She's going for a second opinion, and hopefully that pathology opinion will happen, but thank you.
The questions on the right.
Yeah, Dave Rim from Yale. I really love the lectures, but I have, yesterday we talked about what defines an entity, yes or no. And I wonder if you can start maybe, George, and talk about how you define an entity, genomics versus histology, and just sort of ponder on that for a moment.
That's a wonderful question, David. It's, how can I put that? It's easy when the genomics and the pathology really agree. Like in those low-grade forms of triple-negative breast cancer, where it's really self-evident that an entity is both histologic and molecular at the same time. A more difficult situation is in the context, for instance, of lobular carcinomas, where 80% plus will have icadherin biallelic inactivation plus icadherin loss that have the right morphology. But what we do with those that have the perfect morphology but are icadherin positive? And there are some. And now with genomics methods, we are coming to understand that a subset of those have cryptic rearrangements of icadherin. Others have alterations of other cadherins or catenins that confer the same phenotype. The more we understand of the genomics, the easier it is for us to define these very discrete entities. But from a pragmatic perspective, there are some potential solutions for that, because our inter-observer agreement for the diagnosis of these variants or these histologic subtypes is far from perfect. So perhaps using a histologic diagnosis plus a molecular marker or immunohistochemical marker that helped us lock a subset where we can then apply apply in the context of clinical trials would be useful.
So does the genomics trump the histology, or does the histology trump the genomics?
There's no one-size-fits-all here, David. There are some situations where the genomic definitely trumps histology. There are other occasions where the histology at present trumps genomics.
Thank you.
Okay, on the left.
Simon Hassan, surgical oncologist from Montreal. This question is for Dr. Leubel. With regards to invasive lobular cancer, what are your thoughts with regards to genomic predictive tests such as Oncotype DX and predicting the use of chemotherapy in the context of invasive lobular carcinoma, since we know that the response is perhaps not as similar as invasive ductal carcinomas, and should there be some fluidity in the scores and the thresholds for the use of chemotherapy?
Can you turn the mic on, please?
I'm already tired. The jet lag, I can't push anymore. So this is an interesting question, actually. I would not, based on no evidence, shift the scoring up or down just because we have a lobular carcinoma, which is more likely to be endocrine sensitive. We have a dilemma because very often we think, well, we operate the tumor first and don't give them a preoperative treatment, and then we find a large tumor with nodal involvement where we feel, well, we cannot leave the patient just for endocrine therapy, and then we still treat them and with chemotherapy, and there is then no really need to apply an additional gene expression array because because these patients are of a high stage and there are really no data then for that. But for those with smaller tumors, very often we probably can go without chemotherapy and just with endocrine therapy because they are very endocrine sensitive.
Thank you.
Okay.
Billy, breast pathology from Emory. I actually have two questions for George, but he already answered the first one.
Just one.
First one is lobular carcinoma, invasive lobular carcinoma with eccantharian staining, whether you call lobular or ductal, but I think you already answered that. Second question for adenoid cystic carcinoma. Publications showing that even solid adenoid cystic carcinoma have pretty good prognosis. There's a recent publication of basal type adenoid cystic carcinoma has probably the worst prognosis. More than 50% have metastasis. Similar entity was proposed by Anderson a few years back. They call basaloid triple negative breast cancer. I think with similar morphology with this publication of basaloid adenoid cystic carcinoma. You have any comments on this? Thanks.
Thank you so much. I have to pay you a glass of Krug afterwards, so that I can, because I can elaborate on this diagnosis. So in one of our studies of the basaloid, so-called basaloid variant of adenoid cystic carcinomas, we did investigate then the genomic features of those tumors. And they seem not to be a variant of adenoid cystic carcinoma at all. As a matter of fact, only one of all of our samples displayed a MIB or a MIB-L1 rearrangement. Rather, they have some features that are reminiscent of the adenoid cystic histology, but everything else seems to be different from, in terms of the biology, in terms of the genomics, and in terms of the outcomes. So whether they do constitute a variant of adenoid cystic or they are actually a convergent phenotype of many different adnexal lesions of the breast that have that basaloid phenotype as a final product remains to be determined.
Would you consider rename it? Because when we talk about adenoid cystic carcinoma, those patients generally we think have good prognosis and may not benefit from chemotherapy, but with this very malignant subtype, sometimes we have to have a lot of communications with oncologists. Which one is which? Thank you.
These are vanishingly rare cases, indeed, but in Pedro Mrazavi is here, he can confirm. When we come across one of those, we always flag it to be them to be discussed in the molecular tumor board.
So sorry for, I know that there are more questions, but given the interest time to respect the poster session, I guess we're going to adjourn. And thank you for attending and then have an interest. Please enjoy the rest of the meeting, and then we'll see you in 2023 with the new data.